Hello everyone. In today's session, we will explore disruptive impulse control and conduct disorder. In this lecture, we will cover 6 main topics. First, we'll begin with an overview of what disruptive impulsive control and conduct disorders actually are, and examine the common features that ties these disorders together. Second, we will look into oppositional defiant disorder. This disorder typically appears in childhood or adolescence and is characterized by persistent defiance toward authority figures and frequent displays of anger or irritability. Third, we will discuss intermittent explosive disorder, a condition marked by sudden and disproportionate outbursts of anger where individuals fail to control their impulses even in minor situations. Fourth, we'll explore conduct disorder, which involves a repetitive patterns of violating social norms and the rights of others. Fifth, we'll examine pyromania, a pathological tendency to deliberately set fires. And sixth, we'll discuss kleptomania, a recurrent irresistible urge to steal things that are not needed for personal use or momentary value. First, disruptive impulsive control and conduct disorders are a relatively new category introduced in DSM-5. In the previous version, the DSM-4, these disorders were scattered across different sections. For example, operational defiant disorder and conduct disorder were listed under disorders that are typically first diagnosed in infants, childhood, or adolescence. Meanwhile, intermittent explosive disorder, pyromania, kleptomania were classified separately under impulse control disorder. However, in the DSM-5, these have been reorganized and unified under a single category, disruptive impulse control and conduct disorders. Emphasizing disruptive behavior resulting from failures in impulse control. This reclassification allows for a better understanding of the developmental continuity and shared pathological mechanisms among these disorders. Most of these conditions tend to begin in childhood or adolescence and are closely related to an individual's developmental process. Now, let's move on to the first specific disorder in this category, oppositional defiant disorder, or simply ODD. The main features of oppositional defiant disorder can be grouped into 3 key dimensions. Children with ODD often become easily annoyed or lose their temper over minor issues. They tend to be touchy or resentful, giving others the impression they are easily always angry. Second, argumentative or defiant disorder. These children frequently argue with authority figures such as parents or teachers. They may deliberately annoy others. refuse to comply with rules or requests, and often blame others for their own mistakes or misbehavior. Third, vindictiveness. They may hold grudges or act spitefully or seek revenge. According to DSM-5, if such vindictive behavior occurs at least twice within 6 months, it meets the diagnostic threshold for this symptom cluster. To qualify for a diagnosis, these behaviors must persist at least 6 months and should not be limited to interaction with the family. They must also appear in the relationship with people outside of the home, such as peers or teachers. The severity of ODD is determined by how many different settings the behaviors occur in. For example, children who show diffyang only at home would be considered mild, whereas similar behavior extending to schools or peer relationships would indicate a more severe form. The DSM-5 also provides age-based criteria. For children under the age of 5, such behaviors must occur on most days for at least 6 months. Children with oppositional diffyang disorder often appear moody, easily irritable, and emotionally sensitive. They frequently express anger or dissatisfaction, even over trivial matters, and their emotional reactivity makes them highly intolerant of frustration. While ODD can occur on its own, during adolescence, it may develop into other problems such as substance use, conduct disorder, or even mood disorders like depression and anxiety. This highlights the importance of early intervention since untreated ODD can evolve into more serious emotional and behavioral issues later on. The onset usually occurs before the age of 8, and in some cases, symptoms can appear as early as age 3. This means that early parent-child interaction play a crucial role in the development of this disorder. There are also gender differences. Studies show that ODD tend to be diagnosed more than in girls, whereas boys are more frequently diagnosed with conduct disorder. These differences are more often attributed to variation in social role expectations and how aggression is expressed across genders. Although ODD sometimes diminishes naturally with age, children with experience often experience ongoing conflict with parents and teachers, as well as difficulties in school and peer relationships. Over time, these struggles can negatively affect academic performance and social functioning. So, what causes oppositional diffyang disorder? Various theoretical perspectives have offered different explanations. From a family system perspective, ongoing parents-child conflict is considered one of the most significant contributing factors. ODD often develops in families where parents are overly controlling or authoritarian, and the child has a strong-willed or dependent temperament. Repeated cycles of power struggle can gradually evolve into oppositional and defiant behaviors. From a psychoanalytic viewpoint, ODD is thought to stem from unresolved conflict during the anal stage of development. Specifically, struggles for control and autonomy that arise between parents and children during toilet training. According to learning theory, defiant behavior can be learned through modeling and reinforced through operant conditioning. For example, when a child persistent arguing or defiant successfully result in getting their way, such as making parents withdraw their demands, the behavior is reinforced and become more likely to recur. So, how can we intervene effectively? First, improve parent-child communication is essential. Rather than relying on one-sided command or control, parents should foster open, respectful dialogue that allows emotional expression. It is especially important for parents to acknowledge and accept their children's frustration and anger. When parents fail to do so, oppositional behavior can intensify, particularly during adolescence. At the same time, consistent discipline and clear rules are crucial. If rules frequently change or are applied inconsistently, children may become confused about boundaries and limits. For this reason, parent training and behavioral therapy are often combined to help families establish healthier communication patterns and more effective behavior management strategies. Now let's move on to the second disorder, intermittent explosive disorder or IED. Intermittent explosive disorder is characterized by recurrent aggressive outbursts and a failure to control impulses. Individuals with IED may suddenly explode with anger in response to minor provocations. These episodes can include shouting, throwing, or breaking objects, and sometimes physical aggression toward people or animals. Importantly, these outbursts are not planned or goal-directed. They occur as an immediate reaction to impulse, not as a calculated behavior. According to DSM-5, aggressive behavior in IED can appear in two primary forms. First, verbal expression, such as yelling, swearing, arguing, or making verbal threats. If these occur twice per week for at least 3 months, they meet part of the diagnostic criteria. Second, physical aggression, such as damaging property or physically harming people or animals. If these explosive acts occur 3 or more times within a 12-month period, they can fulfill diagnostic criteria. A key failure is that the intensity of the outburst is disproportionate to the actual provocation or stress. In other words, the magnitude of anger or aggression far exceeds what the situation would reasonably justify. Another important point is that these explosions are not motivated by external gain. They are not premeditated acts of violence intended to achieve money, power, or revenge. Rather, they are impulsive reactions arising from an inability to regulate emotion in the moment. These episodes often cause significant impairment in social, occupational, or legal functioning. For instance, a person may be expelled from school, face disciplinary actions at work, or even encounter legal problem due to physical assault or property damage. Finally, the DSM-5 specifies that the diagnosis only can be made in individuals aged 6 or older. This ensures that such behaviors are recognized as pathologically only after emotional regulation ability has normally developed. The causes of intermittent explosive disorder cannot be explained by a single factor. Instead, it is best understood as a multifactorial condition involving the interaction of biological, psychological, and environmental influences. From a biological standpoint, research suggested that elevated levels of androgen or other hormone imbalances may influence anger regulation and impulse control. There is also evidence of genetic vulnerability. Individuals who are biologically predisposed to low stress tolerance may be more prone to overact or become easily agitated. At the neurochemical level, imbalances in serotonin and dopamine regulation have been linked to increased impulsivity and aggression. In particular, low serotoninergic activity has often been associated with poor emotional regulation and heightened reactivity to stress. From a biological perspective, aggressive outbursts can become habitual through repeated reinforcement. If a person learns, consciously or unconsciously, that expressing anger gets result, the behavior is negatively reinforced and becomes more likely to recur. Emotionally, individuals with experience of rise in tension or anxiety before an outburst, followed by a temporary sense of relief afterward. This emotional release acts as a form of internal reinforcement, maintaining the explosive pattern. Exposure to repeated trauma or domestic violence during childhood can also contribute to the disorder. Children who experience abuse or neglect often fail to learn healthy way of expressing anger, and as adults, they may continue to release pent-up emotions through impulsive or aggressive behaviors. The The onset of IED typically occurs between late adolescence to early 30s. During this developmental period, emotional regulation and stress coping mechanisms are still maturing, making individuals more susceptible to impulsive aggression if other risk factors are present. Intermittent explosive disorder is not an easy condition to treat. In most cases, individuals do not voluntarily seek help. They usually come for treatment only after their outburst has caused serious social or legal problems. Medication can help reduce aggression and impulsivity to some extent. Commonly used drugs include lithium, carbamazepine, benzodiazepine. These medications aim to stabilize neurotransmitter balance, enhancing the person's ability to control anger and manage impulses. However, it's important to note that medication alone is only a temporary measure. For long-term improvement, psychosocial intervention must be combined with pharmacotherapy. A crucial therapeutic focus is learning to express anger in non-destructive and healthy way. For example, patients are encouraged to recognize and verbalize their anger. They also practice nonverbal self-expression techniques, such as taking a short break to calm down before responding. Individuals with IED often has a low tolerance of frustration and tend to explode even at minor provocation. Therefore, they benefit from learning stress awareness and regulate skills. Methods such as meditation, relaxation training, or cognitive behavioral therapy can help them understand the thought, emotion, behavior connection and develop healthier coping responses. Anger management programs do not aim to eliminate anger, but rather to manage it at a controllable level. Patients learn to identify early warning signs of anger and practice pause before explosion strategies through repeated exercises. This process strengthens overall emotional regulation and self-control. Now let's move on to conduct disorder, known in Korean as 품행장애. The core feature of conduct disorder is persistent patterns of behavior in which the basic rights of others or major societal norms are repeatedly violated. According to DSM-5, a diagnosis of conduct disorder requires the presence of at least 3 or more symptoms from 4 behavioral categories: aggression to people and animals, destruction of properties, deceitfulness or theft, and serious violation of rules. These behaviors must persist for at least 12 months, and at least one of them must have occurred within the past 6 months. As mentioned earlier, the DSM-5 classifies symptoms of conduct disorder into 4 major domains, each of which represent a different patterns of violating social expectations. The first domain involves aggressive behavior directed toward people or animals. This includes bullying, threatening, and intimidating others, frequent physical fights, or even the use of weapons. In more severe cases, it may involve animal cruelty or forced sexual activity. This domain is closely associated with a lack of empathy and insensitivity to the suffering of others, and it is often considered an early warning sign of potential development into antisocial personality disorder later in adulthood. The second domain involves intentional damage to property, for example, deliberately setting fires or vandalizing objects. It's important to note that these acts are not simple pranks. They are deliberately, purposely action often motivated by anger, frustration, or revenge. Such behaviors may reflect not only poor impulse control, but also a deeper pattern of hostility and aggression being expressed through destructive means. The third domain involves deceitful or stealing behaviors. These include acts such as breaking into someone's homes or car, lying to gain personal benefit, or stealing items of value. An interesting point here is that this domain is not simply about theft itself, but about our repeated patterns of violating trust. In other words, these behaviors reflect a mindset that prioritize personal gain over social rules or honesty. It demonstrates a disregard for moral boundaries and the expectations of fairness within relationships. The fourth and final domain involves serious violations of rules. These behaviors typically reflect a persistent defiance of authority at home or at school. Example includes staying out overnight without parental permission before the age of 13, running away from home more than twice or once for an extended period, and truancy beginning before age 13. This behavior go beyond typical adolescent rebellion. They represent a consistent pattern of rejecting social and familial structure, often signaling deeper issues within impulse control, emotional regulation, or attachment. Now, let's take a look at the causes and risk factors of conduct disorder. As with most behavioral disorders, there is no single causes, rather a complex interaction of family, psychological, biological, and social influences contribute to its development. The most crucial factor is parent-child relationship. Research consistently shows that harsh or inconsistent discipline, neglect, emotional rejection, and family conflict or violence play a major role. Children raised in homes with abuse, domestic violence, or parental mental illness, including alcohol or substance use problem, are more likely to model aggressive behavior and fail to learn healthy emotional regulation. Children with conduct disorder often have low frustration tolerance. They react impulsively and explosively to minor provocation and find it difficult to cope with disappointment or delay of gratification. From a behavioral learning perspective, problematic behavior may develop through modeling or reinforcement. For example, a child learns that aggressive behavior helps them to get what they want, such as gaining attention or avoiding consequences. That behavior becomes reinforced and eventually habitual. Conduct disorder tends to develop gradually rather than suddenly. It may begin with minor rule breaking, then escalate over time if left unaddressed. Without early intervention, these behaviors can progress into antisocial personality disorder or lead to legal problems in adulthood. When a child has normal intelligence and no co-occurring psychiatric conditions, the prognosis tends to be more favorable as they are better able to benefit from intervention and behavioral therapy. Children of parents with antisocial tendencies or substance use disorder are at higher risk for conduct disorder. This is thought to result from combination of genetic predisposition and environmental modeling, where both inherited temperament and learned behaviors play interaction roles. Conduct disorder is also more prevalent in low-income families. Economic stress, unstable living conditions, and exposure to community violence can all contribute to the emergence and persistence of conduct problems. Conduct disorder often coexist with other disorders, particularly ADHD and oppositional defiant disorder. When combined with ADHD, impulsivity and aggression tend to intensify, making behavioral regulation even more challenging. Finally, let's look at effective intervention strategies for children with conduct disorder. Treatment for conduct disorder is not simply about correcting problem behavior. It requires challenging the interaction patterns within the entire family system. The first and most essential step is to restore healthy communication between parents and the child. Beneath oppositional and aggressive behaviors, there is often a foundation of parental criticism, hostility, and distrust. Therapeutic work focuses on helping parents shift from criticism to empathy and reactive listening. Even this change alone can significantly reduce the child anger and resistance. Children with conduct disorder often grow up in environments with inconsistent discipline or unclear rules. Therefore, establishing consistent rules and using positive reinforcement are central to treatment. Parents are encouraged to immediately prize or reward pro-social behaviors, while antisocial or rule-breaking behaviors should be ignored or consistent disciplined. This approach helps strengthen appropriate behavior patterns through reinforcement. Cognitive behavioral therapy is one of the most evidence-based treatment for conduct disorder. Through CBT, children learn to recognize and differentiate between thoughts and emotions, and to replace impulsive reactions with constructive coping skills. Therapy also aims to increase frustration tolerance and correcting distorted self-perceptions, helping the child build a more positive self-image and self-control. Parenting training goes beyond simply teaching parenting techniques. It helps parents learn to model constructive expressions of anger and effective problem-solving skills. In essence, the focus is not merely to changing the child behavior, but on changing how parents respond to the child. When parents alter their reactions, the child's behavior pattern often improve naturally. Psychosocial interventions are the first-line treatment for conduct disorder. However, in cases where regression is severe or comorbid conditions such as ADHD or mood disorders are present, pharmacological support may be added. Medications such as lithium, carbamazepine, or benzodiazepines can be used to help reduce impulsivity and aggression. Next, let's examine pyromania or pathological fire setting, 병적 방화. Pyromania is not simply about committing acts of person. This is classified as an impulse control disorder characterized by recurrent urges to set fires accompanied by pleasure, gratification, or relief after doing so. First, individuals with pyromania intentionally set fires repeatedly. Second, they experience tension or emotional arousal before the act and feel pleasure, satisfaction, or relief while setting the fires or watching things burn. Third, they show a fascination or preoccupation with fire itself. For example, they may frequently think about fire, enjoy watching fires burn, or feel drawn to object or situation involving flames. Finally, an important distinction: these fire-setting behaviors are not motivated by external factors such as financial gain, political statements, revenge, or attempt to conceal a crime. In other words, The core mechanism lies in internal impulses and emotional tension, which differentiate pyromania from criminal arson. There are several perspectives on causes of pyromania. From a psychoanalytic perspective, fire setting is sometimes interpreted as a symbolic act of releasing repressed or unmet sexual impulses. Fire is thought to resemble to the sensations associated with sexual arousal, and its shape and energy have been interpreted as a symbol of phallic imagery. Moreover, fire represents destruction and sadistic power. So, in some cases, arson may be viewed as an unconscious expression of revenge or as a form of communication for individuals who feel powerless or unable to connect effectively with others. Biological explanations have also been proposed. Neurological dysfunction may play a role, as a higher rates of fire setting have been observed among individuals with intellectual disabilities, alcohol dependence, or certain paraphilic disorders. From a treatment standpoint, evidence remains limited. Some cases, studies have reported benefits from psychodynamic therapy or behavioral intervention, but no single treatment has been firmly established as effective. Next, let's move on to kleptomania, the recurrent, irresistible urge to steal, also known in Korea as 병적 도벽. Kleptomania is characterized by a repeated failure to resist impulses to steal, even when the stolen item have little or no personal or momentary value. Before the act, individuals typically experience mounting tension or emotional arousal, and during or after the theft, they feel pleasure, gratification, or relief. Importantly, these acts of stealing are not motivated by anger, revenge, delusions, or hallucinations. They occur as impulsive acts, not as planned or goal-directed behaviors. A diagnosis of kleptomania is made only when the behavior cannot be better explained by other conditions such as conduct disorder, manic episodes, or antisocial personality disorders. The causes of kleptomania can be explained from both biological and psychoanalytic perspective. From a biological standpoint, studies have reported structural abnormality in the brain, such as prefrontal cortex atrophy or ventricular enlargement. These neurological changes may impair impulse control and inhibitory functioning, making it harder for individuals to resist compulsive urges. From a psychoanalytic perspective, stealing may serve as a symbolic substitute for lost affection or unmet emotional needs from childhood. It can also be viewed as a release of repressed sexual impulses or as a form of symbolic revenge toward someone whom love or attention was taken away. In terms of treatment, cognitive behavioral therapy has shown some effectiveness as well as pharmacological intervention using SSRIs or naltrexone. However, treatment guidelines remain limited and more empirical research is needed to establish consistent therapeutic approaches. Today, we have explored disruptive impulse control and conduct disorders, examining their core features, underlying causes and risk factors, and effective intervention strategies. The behavior we discuss are not merely problem behaviors or abnormal reactions, rather, they can be understood as human responses to unregulated emotions, frustrations, and loss. Therefore, in clinical practice, our goal should not be limited to simply assigning a diagnosis. It is equally important to understand the client's inner experience to form a therapeutic relationship grounded in empathy and to provide appropriate support that facilitate recovery and emotional regulation. I hope today's lecture helps you as future clinicians and researchers. Thank you for attention.